So where do we begin with cardiac rehabilitation? Recent myocardial infarction. If patient has undergone percutaneous transluminal coronary angiography or plasty, that is PTCA, CABG, coronary artery bypass grafting, congestive heart failure, valvular heart disease, but after correction, okay, because till the time the valvular defect is not corrected, the hemodynamic stability is still not achieved in the patient. And which patients we should not begin cardiac rehab with is unstable angina, uncompensated heart failure, complex ventricular arrhythmias like ventricular flutter, of course, fibrillation to know only, then severe pulmonary arterial hypertension, intracavitary thrombus, because where the lot of pressure alterations are happening, the thrombus may get dislodged and it may get lodged somewhere into the arterial circulation, giving problems like stroke or uncontrolled inflammatory pathology, especially of the myocardium. Okay, so these are the strict no-nos for beginning the cardiac rehabilitation. So I will have to make sure before beginning with cardiac rehab, even in the yes category, there is no new onset of chest pain in last 12 hours. There are CKMB levels which are declining. There are no signs of decompensated heart failure, and there is no new abnormal rhythm. So, decompensated heart failure signs are patient is having bilateral pedal edema. When we auscultate the patient, there are basal creps which are present. Patient may have bilateral pleural effusion, ascites, and all these problems may exacerbate when we are trying to do physical activity. So, if patient has all the yes, and patient does not have anything from the blue box, so in that case, we can start with phase 1 cardiac rehabilitation. Then second part of the assessment is check for all the risk factors. The risk factors for especially the modifiable risk factors are smoking, dyslipidemia, hypertension, lack of physical activity, stress, which could be psychological mainly, and body composition. So if somebody is very obese, if patient has diabetes, patient has any substance abuse. So we have to note down all these risk factors. We have to know how in history that how bad that particular substance abuse or substance dependency was there, or how well the comorbidities were controlled, and what is the current status of these. Because in long run, we also have to work on the control of the risk factors. So we have to make sure that all these factors are absolutely controlled. So at baseline, I have to monitor the condition of these things. Apart from this, we are going to do the clinical assessment, mainly focused on the baseline assessment. So we are going to check for the hemodynamic parameters like heart rate, blood pressure. So if I want to prescribe any physical activity, the resting heart rate should not be above 120. There should not be any abnormal rhythm, especially ventricular rhythm. Um, like premature ventricular contraction or ventricular fibrillations. There shouldn't be any conduction abnormalities, especially grade 2 or grade 3 heart block shouldn't be there. The blood pressure should be within the normal limits. It should not be too low, which can be suggestive of cardiogenic shock. It should not be too high, which is suggestive of abnormal or elevated blood pressure. So to rule it out, we have to check the baseline assessment for hemodynamic parameters. This should be ideally done in a supine or a recumbent position. And we have to check what is the positional response. So from supine position, when we are getting the patient in upright position, especially what change is happening in the heart rate and blood pressure. If there is abnormal rhythms which are getting precipitated, it could be suggestive of any latent arrhythmias. Blood pressure, sudden fall could be suggestive of orthostatic hypotension. So we have to check that how the parameters or vital parameters are responding to the positional change. Apart from that, we have to make a note about how's the 2D echo, what is the ejection fraction. So that will give us an idea about the contractility of the heart. Then on ECG, if patient is having ongoing ischemia or whether it is an old infarct now. So whether it is evolving MI, whether it is old MI. So ECG will give us an idea about that. Apart from that, as a physiotherapist, because we are going to prescribe activities, we have to focus our assessment that when we are prescribing any physical activity, how the heart is reacting. So whatever are the hemodynamic parameters we have noted, when we are prescribing minimal physical activity, how the heart is responding in terms of change in heart rate and blood pressure, that has to be recorded. That is activity tolerance. Wherever possible, we can do standard field exercise test, also like 6-minute walk test. And what is the recovery after the exercise? So all these things should be part of the clinical assessment. Now, when we are speaking about abnormal responses, whenever we prescribe any physical activity, the heart rate should increase, blood pressure should increase, but it should be with respect to workload. Now, with phase 1 rehabilitation, we are not exceeding 5 minutes activity. So, blood pressure should not fall beyond 10 mmHg and it should not increase above 40 mmHg. So, these things have to be kept in mind whenever we are prescribing any activities. Now, when we actually come to prescription of activities, imagine that we are starting with a very minimal activity, that is 1 minute activity where patient is lying and practically doing nothing. From there, we have to get the patient so that they are able to do most of their functional activities. So we have to get the patient from 1 minute to at least 4.5 to 5 minutes, which is required for most of the self-care and domestic activities. So we are going to design our exercises in a structured and progressive manner, wherein we are taking our patient from level 1 to level 5. So level 1 is on when we are beginning, we have screened the patient, our patient is all okay, in whom we can start with phase 1 rehab. We'll start with bare minimum activity, that is 1 to 1.5 minutes, which are not but in bed exercises, ankle pump exercises, so that the circulation in the lower limb is established properly. Lung volume expansion exercises can be started, especially in open heart surgery. And these are very safe because they are very low level activity. From here, we can go a step ahead and we can give slightly strenuous exercise, wherein we are now recruiting a large group muscles like knee and hip, wherein lower limb in bed exercises can be started, and we can progress to supervised limited room ambulation, maybe around the bed within the ICU. Then we can gradually progress to exercises in standing and hall ambulation, 5 minutes or so, how it will be tolerated. From there, we can increase the duration, we can add trunk exercises, and that's how we can progress from level 1 to level 6 or MET 1 to MET 5, wherein my patient should be able to at least climb one flight of stair with a normal physiological response towards the exercise, or they should be able to complete a 6-minute walk test, whatever is possible. Uh, Now, whenever we are progressing from level 1 to level 2, this is my progression criteria, that my heart rate increase should not be more than 20 to 30 beat per minute as compared to the resting. So if the resting is 60, it should not be more than 80 for conservatively managed patient, should not be more than 90 for surgically managed patient, or some intervention is done, or the patient should not show any chronotropic incompetence. Ki, there is no change in heart rate at all, because that is also not normal. Systolic blood pressure rise should be between 10 to 40 mmHg. There should not be appearance or increase in number of premature ventricular contraction. There should not be any ST segment changes. So obviously, whenever we are progressing, we have to have at least 1 or 2 leads of ECGs, which should be visible on the monitor, wherein if there are any ST segment changes, which will be visible. And of course, if patient did not have any chest pain with activity, patient should not land up with any chest pain or any new cardiovascular symptom like this. It should not be dizziness, excessive sweating, chest pain, radiating pain. Patient should not have all of these. Okay. So if none of these are present, that means that particular progression is suitable for the patient and it is okay to progress. If any of these is present, we have to step down and go to the lower activity. So that we have to keep it in mind. Apart from that, this is not a day-wise progression. So not necessary that I can achieve only level 1 on day 2, day 1, then level 2 on day 2. Nothing like that. You can club the levels and you monitor the patient. If it is okay to progress, you progress. If it is not okay to progress, then step down. Frequency of the exercises is 2 to 3 times per day. Intensity, I have already spoken about. Heart rate plus 20 at rest plus 20 beats for conservatively managed patients, maybe thrombolyzed. And wherever intervention is done, for example, PTC or CABG, it is slightly safer because whatever was the clot or thrombus which was present, it is already taken care of. So blood supply is kind of restored. So safety limit is more. So I can go little aggressively with HRS plus 30 beats. And a single session of exercise should not exceed 20 minutes. So this is how typically an exercise session would be for the patient. And this is how a day-wise progression grid looks like. Uh, so on day 1, where patient was in bed and we have given minimal privileges like probably bedside commode, we have started with ICU ambulation, room ambulation, and then gradually we have progressed with the duration wherein our patient can walk 5 to 10 minutes and probably 1 flight of stair. So that is how we have done a day-wise progression. Patient education is an integral part during phase 1 rehabilitation. Especially patient needs to understand why cardiac rehabilitation is necessary, why they have to be cautious, but still they have to stay active. So we have to be um, emphasizing enough on the need for the physical activity, but it has to happen in a controlled environment. So it has to happen strictly with under supervision. So maybe in the beginning we can give them basic information about the uh, disease or the event and how their treatment plan would be. And before discharge, we have to make sure that we are giving them sufficient instruction about whom to contact, how to identify the red flags, what are the danger signs, what is okay if they feel during the exercise, what are going to be the do's and don'ts, how to self-monitor. So all these things are very important parts of patient education. And of course, at the time of discharge, we have to make sure that we are referring the patient into the supervised OPD based rehabilitation, because this is not the end of it. After this, patient is going to go home, settle down, but the need or necessity doesn't end over here. From here, um, to prevent the future episodes, patient should be able to do at least moderate intensity activity for 30 minutes. So from here, when patient has to reach over there, we have to make sure that those activities are absolutely safe for the patient. And hence, the enrollment into phase 2 rehabilitation is extremely important. And that is where patient education and counseling are integral part of phase 1 rehabilitation. There are certain special considerations after thoracotomy, that is open heart surgery, which are to be taken into account during phase 1 rehabilitation. That preoperative exercise training improves physical fitness and reduces risk developing PPCs. So the chest physiotherapy, preventive breathing exercises, diaphragmatic deep breathing exercises, to or rather lung volume expansion exercises should be performed. There is some variability in the protocols over here. There are certain centers who use PEP devices prophylactically, but ultimate aim is that Atelectasis should be prevented. Post-pulmonary complication should be prevented. Patient should not have retained secretion because that is going to increase the symptom burden for the patient. Uh, the research also says that inspiratory muscle training is associated with increase in exercise capacity, respiratory muscle strength, as well as quality of life, and hence it should be included early in the cardiac rehabilitation. And breathing exercises should be done regularly, at least 8 times in a day after every hour, probably in every waking hour. I have already emphasized on patient education. There are different patient education models which are available. You can go for a structured education protocol, or it can be a tailor-made protocol wherein certain models say that you have a dialogue with the patient, understand the needs, that what patient needs, and then where the patient need to be trained with respect to coping strategies. So learning and coping strategy or consultation program empowerment, motivation and medical adherence, that is EMA. So such patient education models also can be incorporated, which help in making the patient education protocol more tailor-made. So whichever way we go, phase one is circling around a good amount of patient education. We have to start with structured progressive mobilization for the patient so that patient is able to become independent in most of their daily activities, but should not have risk of any adversities like readmission or associated complications. And and hence we are going to add patient education and exercise protocol. The patients who are discharged from the hospital but they are not able to cope on their own, so for them they are recommended to enroll themselves into skilled nursing facilities or home rehabilitation, wherein a physiotherapist or a rehabilitation expert can visit their home and help them with the training at home. And then they can, after 4 to 6 weeks, we can begin with a phase two rehabilitation after a baseline stress test. So this was about phase one rehabilitation. Stay tuned for further phases of cardiac rehabilitation. With this, we conclude today's Physio TV classroom session. And I thank you, our principal, Dr. Apurva Shimpi, our technical team, our management for giving me this opportunity to be live on Physio TV. And thank you so much for viewers of Physio TV. Stay tuned for more educational videos. Thank you so much.